Haemovigilance in neonates and children, also known as Paediatric SHOT. Haemovigilance reporting schemes such as SHOT, the UK Serious Hazards of Transfusion, give us information on adverse outcomes from transfusion, which can be subgrouped into errors and pathological reactions. This video describes the particular lessons learned from paediatric haemovigilance reporting for transfusion of neonates, infants and children less than 18 years of age. It is important to look specifically at reports in the paediatric age group, which make up approximately 8% of all reports to SHOT, as they can differ from adult reports. Neonates, in particular small preterm babies, are frequently transfused and are vulnerable recipients with smaller blood volume and different physiology to older patients. Blood administration is therefore more complex, with small volume giving sets, pumps and syringe drivers. Specific blood components are provided for neonates and infants with additional safety features. Each year, SHOT receives around 130 paediatric reports for recipients aged less than 18 years, with evidence of a disproportionately high number of reports per transfusion compared to adults. Approximately 2/3 of paediatric reports are errors and should therefore be preventable. Overall, paediatric error reports show similar types as in adults, but they are particularly overrepresented in 3 error categories, reflecting the increased complexity of paediatric transfusion, especially in neonates and infants. These 3 error categories will now be described in more detail. The first one we will talk about is incorrect blood component transfused, wrong component transfused. For example, adult OD negative units are unsuitable for neonatal emergency use and are sometimes used inappropriately to resuscitate neonates, despite availability of neonatal emergency packs. Local measures should be in place to help guide staff to select the correct component in emergency situations. The second error category we will cover is incorrect blood component transfused, specific requirements not met, such as provision of irradiated cellular components. This may occur due to poor communication when children's care is shared between hospitals. Errors in the transfusion laboratory are a significant contributing factor to both wrong component transfused and specific requirements not met. It is important for anyone working in the laboratory to remember to take into account maternal antibodies for babies less than 4 months old, that babies may have been transfused and transferred from elsewhere, and to select the correct blood for the recipient. The third error category to pay attention to is avoidable, delayed or under or over transfusion, abbreviated to ADU. Under and over transfusion is a particular problem for paediatrics. Let's look at some of the issues which contribute. Administration errors reflect the need for vigilance when setting up infusion pumps and complex administration sets. Errors in calculating and prescribing transfusion volumes, including by units rather than millilitres, may result in significant under or over transfusion. Blood components should be prescribed for children in volumes related to their weight. Clinical staff who prescribe blood for paediatric patients should not do so unless they have been given training in weight-based prescribing of blood components. Overtransfusion can lead to transfusion-associated circulatory overload, known as TACO, and it is important for clinicians to be aware of this possibility, including for neonates. The remaining third of paediatric SHOT reports are pathological reactions. Febrile allergic and hypotensive reactions, abbreviated to FAHRs, account for approximately 1/4 of paediatric SHOT reports. Reactions to platelets are the most commonly reported for the paediatric age group. These are usually allergic and can be severe, emphasising the importance of ensuring that prophylactic platelets are prescribed appropriately. It is important that pathological reactions in neonates are not overlooked. Neonatal exchange transfusions are a specialist procedure performed somewhat rarely, resulting in a lack of expertise. They require special components with a short shelf life with which staff may be unfamiliar. Following repeated reports to SHOT relating to neonatal exchange transfusions, SHOT recommends that in hospitals with neonatal intensive care units, attention should be paid to laboratory staff training regarding the specification and ordering of components for neonatal exchange. There is a risk of high potassium associated with transfusion, particularly following rapid large volume red cell transfusion to infants or to others with significant medical problems. This can rarely result in cardiac arrest and death, although SHOT has received no reports thus far. Given the potential risk, the British Society for Haematology Paediatric Transfusion Guidelines recommend using fresh blood for neonatal and infant cardiac surgery before the end of day 5 and checking potassium levels in the bypass fluid before connecting to the patient. Hospitals should have clear paediatric transfusion guidelines for different patient groups, readily available in all paediatric areas. To assist hospitals, there are educational resources available. The British Society for Haematology Paediatric Transfusion Guidelines are available online, as is the Blood Components app, which should be used in conjunction with the main guideline. Educational resources are also available from SHOT, including the SHOT Bite for neonates and paediatrics. Further information can be found at shotuk.org/resources/current resources.